All right. Hi, everyone. I guess we can get started now. Well, I wanted to welcome everyone to our November 15th session of the Virtual Learning Collaborative, Health Systems Assessment, Implementation, and Follow-up Activities. Oh, excuse me, made possible in partnership with the CDC Division of Viral Hepatitis. So my name is Zakia Grubbs. She, her pronouns, and I'm a manager on the hepatitis team. Joining us today are presenters, Danica Cuncio, Viral Hepatitis Program Manager at the Philadelphia Department of Public Health, and Catherine Van Cleve, Epidemiologist with the Maryland Department of Health. The format for today's session is as follows. We will begin with a presentation by Danica on the Health System Assessment Toolkit, followed by a discussion with Catherine and Danica. So feel free to use the chat to introduce yourselves and your jurisdictions, and if you all have any questions. So this is our last VLC session for the calendar year, and we will see you all again in February. So I will turn it over to Danica to get us started. So thank you.
Thanks, Zakia, and hi, everyone. Let me share my screen. Okie dokie. So as Zakia said, I'm going to briefly talk about the toolkit that we made in partnership with NASDAD and others to help facilitate folks doing the health system assessment for our CDC 2103 grant. Let me try to advance this. There we go. So we released this in August 2023. Hopefully you have all had a chance to take a look at it. If not, I see Zakia put the link in the chat, so please feel free to open it up now, look at it. I'm very briefly going to walk through some of the sections and thought process behind each of these sections, but I'll share a couple of examples associated or for the health system assessment, but please feel free to put your questions in the chat. We'll have lots of time to discuss any questions or commentary for the health system assessment. I know this has been a heavy lift for folks, so we hoped to take a little bit off of your plate with this toolkit and hopefully with this VLC today. So why are we doing this besides the fact that 2103 tells us to do this? The logic is good in thinking about how we can improve testing and linkage for hepatitis B and hepatitis C in your jurisdiction. So thinking through how we can be achieving elimination, it's really important to be thinking about system level changes to do this work. Well, you can't do it all yourself. You might be the only person in your jurisdiction doing anything hepatitis related. Maybe there's a couple other folks. So to really push things forwards and move the needle, we really need to collaborate with our health systems and see what's going on out there. So to do this, we really need to gather this information to inform our resources and technical assistant needs and requests that we're formulating to accomplish this work. It's also an opportunity to strengthen relationship with key players who can actually implement some of these activities that we have, in the grant and then more broadly in our elimination plans. So who to include? It's really important to collaborate with your surveillance team to do this work. We have to, according to the grant, identify the 5 highest volume health systems for hepatitis C and or B testing. So there's different resources everywhere. And I think that that's the biggest thing that we acknowledge and CDC acknowledges coming into this health system assessment is everybody has different level of resources, whether it's surveillance data or prevention resources to do any of this work. So there are going to be different approaches in every jurisdiction. You might have negative antibody testing that you want to include with that you're able to include because you collect it. You identify multiple major academic institutions that have multiple hospitals in their systems. So data going in and data coming out is going to be very different. You might also want to be including hepatitis B, and therefore you include surface antigens and DNA tests as well. But I think that thinking through what you're the questions you're trying to ask, and the best data you can have to inform that is going to go into who identifying who you should be speaking to. And that might look different everywhere too, right? You might have these big systems. You might have an FQHC that does a really good job of testing, and so they pop up on the top of your list. So being mindful of that too is important in going forward with who you are doing, what health systems you're identifying as being the contact folks for this work. So once you identify your key groups to reach out to, how do you do this? So in the toolkit, we identify several ways of doing this. The primary ones for this work that we elevated were doing a questionnaire. So doing a survey, you can do this electronically, usually the easiest way of doing it. You could also do it on the phone, but having a brief survey to identify the key questions you want to talk about for this work. And then an alternative is doing key informant interviews or focus groups with organizations, pulling in folks to have 30 to 60-minute conversations about the questions you want to discuss are really probably the best ways to do it. And then supplementing that. How can you supplement the information that you collect during these questionnaires or these interviews? So requesting written protocols and resources from organizations can be a really great way of doing this. Using as much surveillance data as you have to facilitate. You could do interviews with patients that you identify through your surveillance or in brief intercepts in the field. So if folks are coming out of a clinic, interviewing them there, though you definitely should have a conversation with the site about that before doing that. Going on site and doing a assessment on site and reviewing processes and watching things in action. It could be a really great way of doing this. It's also pretty resource intensive. And then looking for additional data sources. But, these are all different ways to do this. You have to calibrate what you have capacity for and what makes the most sense for your organization. And think about the limitations involved in each of these and what the efficacy of the data is going to really be. If you do a questionnaire and you only get so much feedback, or you don't know who to contact, is that going to be the best way to do it? Are you going to get the most impact after you collect the information and you go forward and try to reach out again if you haven't built a relationship? Are written protocols going to be the most informative because you don't necessarily know who is following protocols? So it might be a hodgepodge of all of these to really accomplish what you're trying to do and collect the information you're trying to collect. So what to ask, again, really dictated by your capacity, dictated by your resources and what you're trying to do. So first and required is addressing Hep C screening methods. You probably want to be including questions about reflex testing, universal opt-out models, simplified order sets in EMRs, where it takes the onus off of the providers to do pieces of this work. That's required. You could add in Hep B if you have capacity and authority to do so. Thinking about questions about policies on paper versus practice. So like I said, just because an organization has the policy to do certain tests, are they getting done? If you say, oh, universal testing is followed in your practice, but really it's probably only one provider doing it, that's a very different conversation. And so how can you ask questions to elicit these responses that really get to what is being done by providers and for patients in each of these settings? Are national recommendations being followed? Do you want to ask, do you follow national recommendations, or do you want to ask questions that clarify if folks are doing that? What groups are being tested? When are they being tested? At what point? So thinking through your approach to some of these is really important too, not just what you're trying to get at. And then again, you can go beyond testing. You can include questions about linkage, about vaccination, and about treatment. If you're only hoping to do this once, it might be a good strategy to include those questions and really answer the holistic package of services, answer questions about the holistic package of services in these settings. In the toolkit, and I really encourage folks to look at these, we have some best practice, three appendices that I encourage you to look at. These best practice outlines can help you formulate some questions and formulate expectations to get at some of these questions. Again, you don't want to just ask, do you screen? You want to talk about what that process looks like, who's being tested, how do people get results, et cetera, et cetera. And so in this appendix, we included information that might be helpful, especially for folks who are newer coming into the field, about some things to consider going or to be included in some of these questions. In the second, and we broke that down too. We, oh, excuse me, I'm trying to navigate this on my multiple screens. We broke this down by screening and then linkage, vaccination, and treatment. And so hopefully that's helpful for folks who are honing in on different topics. We also included some factors for folks to consider, including bundled testing. Orders can facilitate providers ordering all tests. So again, some subject matter expertise embedded in this document to help guide you in your questions, whether they're in a survey, in person, or in a key informant interview on the phone, what have you. And then we also included some example questions. So thank you to the jurisdictions that included or shared their experiences and their questionnaires. And we put those in there again, in putting examples in that you can use and adapt for your health system assessment. So you have all these questions you want to get the answers to. Who are you going to ask? So this is probably the hardest part. You will obviously want to choose folks who are going to give you the most response and the best answers to your questions. You send this to a CMO, they might not know the answers. They also might not even know who to send it to get the accurate answers. So you're going to have to navigate this with each health center uniquely. It might be helpful to think about, rather than contacting leadership within a whole organization, if you're talking about an academic medical center or system, that could be a lot of different settings that are being addressed here. So you might want to hone in on different clinic settings or a few specialties to be, getting the best response and the most helpful response. So for example, who do you think should be testing based off of guidelines, and really work on contacting them. Leverage champions or contacts if you have them, just to get referrals, direct connects within the organization. But again, this might be the hardest part for folks, but really trying to spread the net wide to get a good response is probably going to be your best bet. And then feedback after the assessment. So this is going to be, for some, the hardest part of it. If you can get responses, getting folks' feedback is really important. We don't want to have this be a one-way transactional relationship. We want it to be two-way. We want to be giving back, and we want to be sharing information. You don't want to just do this assessment and have that information on your side. You want to be productive with it. So really trying to give feedback about successes, strengths, and also opportunities for growth, and examples of room for improvement for these organizations that you're speaking to. Also thinking about an opportunity to disseminate it more broadly to stakeholders so that they can see what resources are being offered. You could also play the shame game if that's the angle you want to go and highlight how some systems are doing a better job than others. We know competition and money talks, so maybe that's a way of pushing things forward, but you have to make that call yourself. If you're trying to build relationships, it's really helpful to be constructive. So again, thinking about opportunities for growth, resources you can share, connections you can facilitate between champions in your jurisdiction with other experienced sites for these health systems, to give them the opportunity to grow, to give them the resources to grow. Leveraging existing recommendations and models that are out there, sharing those. Unfortunately, we think people know about them if we know about them, but just because CDC blasts it doesn't mean it gets to every provider. And so really sharing these existing resources and recommendations from other organizations is helpful and important. And then presenting opportunities to continue the collaboration. You really want to be forging a relationship here as best as possible. And so having this be an ongoing conversation is a really important one. And then at the end of the toolkit, just to support some of this, we put some resources down so you can easily access recs and other tools to facilitate some of these discussions. There. And then, for health departments, what can you do? So you're talking about what the organization can do. What can you do? So really taking, again, this information, identifying areas that health systems clearly need support on and improvement in. What programming can you facilitate or provide to folks? Can that be education? Can that be materials or a linkage to care guide, what have you, maps that have vaccinating locations for easy access, things like that. Are there policies that are needed to facilitate addressing some of these barriers? Some things are just beyond a provider. They're beyond a CMO. They're the law. And so is there anything that we can do to help push things forward on our end? So I'm going to give some brief examples. We had some, like I said, we have this question bank, Maryland on the call, and California and Montana and Philadelphia all contributed their examples of questions that we put together for this work. So they're there. I just want to share briefly about the Philadelphia Department of Public Health System Assessment. And this is just what worked for us and what we had resources to do. We did key informant interviews with 4 health systems representing over 10 hospitals and dozens of primary care offices. We selected the key informant format because we've just had difficulty in the past with surveys and reaching out to folks this way. We also wanted to build relationships. We stuck to 30-minute meetings to try to accommodate really busy clinicians and their schedules. We did do a Survey Monkey with our key questions to all the FQHCs in the city because we knew they accounted for a large amount of testing as well, but we didn't have capacity to reach out to 26 sites to do this work. So we targeted our outreach to primary care, family medicine, and OBGYN groups. We also spoke to infectious disease practices inherently because they were brought into these conversations, but it was very beneficial to have their expertise on the calls as well, even though we knew they were probably doing exactly what they needed to in terms of testing. We had several CMOs join the calls, which was really exciting so that we could see that practice change could potentially happen. And we focused on both hepatitis B and hepatitis C, and we talked about testing, linkage, and treatment, as well as Hep B vaccination. We created a feedback report. We included some background data that informed this work, as well as resources and recommendations. We included successes and brief overviews, as well as challenges that we observed through our conversations, and some solutions we thought might be helpful for folks. We sent this via email to the people who we had spoken to as a part of our key informant interviews, and we were able to get responses from 3 out of the 4 groups so far, and have met with them all again to review our takeaways and talk about action items. And so we're going to be pushing for that 4th site as well. And then we are planning for follow-up meetings with all of the groups in a few months, because in these conversations, they came up with independently several things that they could be doing internally, providing that, internal knowledge to apply some of these strategies. And we want to be able to talk through follow through, and has it worked? And if not, how can we facilitate, or what are they going to do to push things forward? So people were really excited to have these conversations about practice improvement. And I think part of the success was our framework of it, that there were successes, they are doing good things, but what else can be done? And that we're realistic about some of it as well, staffing being a big barrier. Excuse me. So just some examples of our results and subsequent feedback. One health system, they follow Hep C screening, but only for baby boomers in their primary care offices. They did not seem aware of more broad universal recommendations, which is disheartening. So we shared universal testing guidelines with them. We also shared that there are many EMR order sets for adults that follow things appropriately. And so we can connect them with organizations that are doing this work. And then we offered provider education as well to help supplement clearly some knowledge gaps for folks. And then for other health systems, one was following all Hep C testing guidelines. They offer Hep C treatment and referral to care, but they do offer treatment in-house in the OBGYN and primary care units, but Hep B is not quite universal yet. They're building an order set and referral pathway for the Hep B triple screen in their primary care and family medicine and OBGYN settings. And so we will be meeting with them to have those conversations moving forward. So I'm going to stop talking and let Catherine share their experience in Maryland. And sorry for the very fast overview. We want to talk about this with you guys too.
Hi, everybody. My name is Catherine Van Cleve. I am the epidemiologist at the Center for Viral Hepatitis in the Maryland Department of Health. Can you see my slides and hear my voice?
Yes.
Okay, cool. So I'm just going to go over what the Maryland experience was like in launching our hepatitis C provider survey, some of the unique challenges that we faced in this process, and just generally what our experience was like. Before I begin, we always include our mission and vision in every presentation. Everything we do at Center for Viral Hepatitis is to in alignment with the services, providing services to promote optimal health and well-being for all Marylanders. We also have a commitment to not only health equity, but social and racial justice, with a nice little visual to demonstrate what that means. So jumping in, just a bit of background. As you all know, we were conducting our provider surveys in accordance with the CDC PS 2103 short-term outcomes. You can see on the right our activities and process measures with the goal of improving our hepatitis B and C testing across the state. We actually did this in two parts. The first was a hepatitis B provider survey launched in 2021 with the objective to identify gaps in knowledge and infrastructure for hepatitis B testing and management from a provider's perspective. And then subsequently, we used the framework from the hepatitis B survey to create a hepatitis C survey, which was launched 2 years later, this year, 2023. So our planning process involved developing a concept note in which we outlined our proposed objectives, the survey methodology we were going to use, the survey tool itself, a list of proposed providers and health facilities that we hoped to reach with the survey, how we plan to disseminate it, what our analytical plan was, and how we would disseminate our findings. So after developing this concept note and the survey tool for the hepatitis B survey, this was back in 2021, we consulted with NASTAD, HBI, which is a community-based organization operating out of Maryland, DC, and Virginia. And then our Maryland HCV Test and Cure partners. They piloted the survey tool and we incorporated their feedback before we disseminated it more widely. And with all of that, we were ready to launch. So for the Hep B provider survey, you can see a flyer on the right with a QR code that took providers to the SurveyMonkey which is what we used as our survey platform. We were able to do this with technical assistance from two large organizations, Health HIV and Alive Maryland. We had partnerships with both of them, and they really helped make this SurveyMonkey possible, as well as sort of marketing to providers. We got a lot of support from them. But between the launch of the hepatitis B survey in 2021 and the hepatitis C survey, which was in 2023, we had some changes in circumstances. We no longer had the same technical assistance available to us, and we had staff turnover. So we had someone new working on the project who hadn't been involved in the hepatitis B survey. And we were not able to use SurveyMonkey this time. We actually ran into a somewhat unique obstacle in our survey dissemination, in that we tried to create a Google form survey and use Google as our platform. But the other circumstance that had changed in between 2021 and 2023 was that Maryland suffered a cyber attack towards the end of 2021, which resulted in a massive data breach and led to changes in our cybersecurity. So what we didn't realize when we launched our survey was that because it was housed on a maryland.gov Google Drive, only people who had a maryland.gov email address were actually able to open the survey. So we got this feedback from providers saying, hey, I can't actually fill out this survey. And we had to really rapidly try to adjust and figure out a way to get the survey out without having a huge temporal lapse between the launch, the first launch and the second launch, basically. And unfortunately, the sort of Band-Aid solution that we came up with was just to type out the survey in a Word document and email that to contacts from the facilities that we identified. We did identify our high volume testing facilities. And so we tried anyone who we could find a contact for. As far as providers, we emailed this out to them. Particularly, we emailed it out to our local health departments, as well as our HCV test and cure clinical partners and community partnerships. So as you can see, this is a summary of our survey participants. Unsurprisingly, we had the largest subsegment of them belong to local health departments. We expected this because these are the people with whom we communicate really regularly, so they know us, they talk to us all the time, and so we were able to get buy-in from these local health departments. Oh, and we had 20 unique respondents representing 17 clinical sites. Unfortunately, as you can see above that local health department bar, we were not able to get a lot of primary care providers and people in like family practice settings to give us that same buy-in. We had a lot. This was a select all that apply, so some organizations identified in multiple categories, but we were not able to reach the population that we were really hoping to get feedback from. And that's just something that we couldn't really control. We did our best to reach them, but we knew when we did that Word document, it's not only really labor intensive for us to then process those results, try and document them, move them over into an Excel format. It's also labor intensive for providers who we know are really busy and don't want to take the time to download a document, fill it out, and then email it to us. So it was just kind of unfortunate circumstances that we weren't able to reach a lot of the population of providers in our state that we hoped we would get feedback from. I won't go too into detail on all of our findings. We asked a lot of questions, but here are a few of the key questions that we were interested in answering. We wanted to know about providers' awareness of testing recommendations. All but one respondent reported that they were aware of the current recommendations. We wanted to assess how well or what kinds of HCV testing were being conducted at each site. We assessed this in a two-part question. First was a multiple choice asking, does your site offer antibody testing, RNA testing, both, or neither? And 15 respondents reported that they offered both antibody and RNA tests, while 2 reported that they only did antibody testing. Our follow-up question was actually a free response where we asked the providers to detail their process with the hope that they would tell us like what their process was if they were doing reflex testing, if they did it as part of an opt-out system. But unfortunately, in our free response question, providers interpreted it in different ways, and so we again didn't get all of the information that we were hoping with that question format. Some providers interpreted it as like, what setting are you conducting the testing in, rather than telling us about their testing process in terms of which tests they offer, in what order, as part of an STI panel, that kind of thing. So we learned something about how we worded our questions. We wanted to know if people were offering testing at no cost. 15 respondents said they did. And we also asked about electronic medical records prompts and reminders. And 4 respondents reported using those in their practice. Some of the other questions I won't linger too long on. We had we asked about patient navigation services, with things like facilitating referrals, providing appointment reminders, peer navigation, that sort of thing. So here are those responses. We wanted to know about the obstacles that providers faced in trying to provide treatment for HCV. As you can see, a lot of people reported that both prior authorization as well as approval for extensions or restarting treatment were significant barriers to providing treatment. And so those are things that we'll try to look into from a policy side to help make it easier for providers to treat HCV. And now I'll just go quickly into some of our challenges with disseminating. As you've already heard earlier in the presentation, staff changes were a huge challenge for us. In the 2 years between the Hepatitis B survey launch and the Hepatitis C survey launch and analysis, we had 3 different people in charge of this project. We had one person who did the Hep B survey, they left. The next person started the Hep C survey, and then I came in the middle of that launch. So it was a lot of turnaround and people coming in who weren't there for the beginning of the process. We also had issues with our survey platform, as I discussed, just because of our cybersecurity situation and a lack of technical assistance on the Hepatitis C survey. It got pretty messy there with the Word documents. And these last few points really go into just how difficult it was for us to reach providers in clinical settings outside of local health departments, because we just don't have the same relationship with those providers as we do with the ones operating in health department settings. And it was just really difficult to get people to have that buy-in, to be willing to spend time filling out a survey, whether that be on the Google form, which is how most of our responses came from people who were able to access it, or the few people who we were able to get to fill out that Word document survey. It was a big ask, and those providers who didn't have a good relationship with us, we just couldn't get a response, frankly, and that was unfortunate. So finally, here are our recommendations and conclusions. We do recommend using a mix of assessment methods, both quantitative and qualitative, for your assessment, but do be mindful when you have qualitative questions that you are very specific, because we did learn that people will interpret questions in ways that you do not anticipate. So that's where piloting can come in handy to try to make sure that your qualitative assessments really get the information that you're looking for. Try to keep it simple. Don't use a Words document if at all possible. Um, do follow up with providers. Keep sending emails within 2 weeks of when you send out the survey. Just keep trying to reach people. Have your analytical plan ahead of time, and then consult NASDAQ, especially this toolkit that Danica just presented on. It's going to be so useful for just to have other jurisdictions templates that you can learn from. Always, we recommend using infographics whenever possible to kind of draw people's eye in when you are disseminating your findings. And then use the information that you gain, put it in your elimination plans, look into what the providers are telling you, and disseminate your information as widely as you can. So that is all I have, just on a giving an overview of what our experience looked like, some of the roadblocks. We did have a bit of a clunky rollout with our hepatitis C survey, and we hope that everyone can learn a little bit from the challenges that we faced. So thank you so much for having me. And I believe we'll move into a question and answer session now.
Catherine, that was really great to hear about. Thank you so much for sharing your experience in Maryland. These best laid plans never really roll out that way, we all know. And I think that is what is frustrating, certainly for folks, especially when they want to do something that is impactful. But I think you guys did so much that was really, really thoughtful and helpful. And I think sharing your experience is definitely going to support folks moving forward with their work. I have a couple questions for you, and I mean, I don't know if you have any for me, so feel free to toss them my way too. But I think just number one, you guys approached this as doing a Hep B survey first, followed by a Hep C survey, and I wonder if you could share if you would do it that way again, and if there were strengths in doing that, or if you think that contributed to some of your big challenges.
Yes, I think that was something in creating this presentation that I was thinking about a lot. And I admittedly was not there when that decision was made, and so I don't have the full information into what informed that decision. I'm sure that they had the epidemiologists before me had good reasons for wanting to do a more targeted approach to look at Hep B and Hep C individually. Unfortunately, I do think that I would recommend doing it as one single survey. Like I said, you don't want to overburden providers. And we did have a really long gap in between times with turnover in between. So I think that keeping it as simple as possible and doing it as one survey would be, if we were to do it again, that would be the way to go. Also, because we had different resources at the time when we launched the first survey.
Yeah, that second survey, it sounds like you hit every wall possible.
Yeah.
I really loved how you guys engaged community members and community organizations in framing the questions and inclusion and approach. So I was wondering if you could share, if you know off the top of your head or remember any of the feedback that you received from those groups in questions that you could include or approaches. If not, I know it was a while ago now.
I'm not aware of what that feedback looked like. It was before I got there that they incorporated that. I think that it probably informed a lot of the questions, particularly about barriers. because they could provide sort of some inference into um, into barriers that we may not have thought of. And actually, our barriers have changed in the meantime. We had people who were still saying that fibrosis staging was a barrier for Hep C treatment, even though that policy has changed. So we were able to identify in that case like a lack of education on behalf of providers about how policies have changed, that shouldn't be a barrier anymore. So hearing that, that providers thought that was still a barrier, informative. But yeah, I wasn't there for that part of the planning. I think that the barriers would be the place where we got the most feedback.
Yeah, I could tell from some of the metrics you showed, some of your results, that it looked like probably some community informed information. So that's really great. And then thinking about also the free text fields, you indicated some barriers there, where it can be a huge opportunity to get some of that detail and that information that maybe you didn't include or didn't know about, but it can be really fraught with misinterpretation and misuse as well. And so would you have any advice on how to approach that for folks moving through this if they were to do a written survey?
Yes. So I think that when you're doing the qualitative questions, you're kind of walking a line between if you're doing it in a survey that you want to disseminate widely, you kind of can't take the same approach as a key informant interview where you can ask follow-up questions.
Mm-hmm.
And so you want to be mindful that a lot of different people from different backgrounds are going to be taking this survey. We had people from social services taking this survey who had completely different background from a clinical setting. We had a really wide variety of people, and they have different levels of education about their own processes for HCV testing. Some of them just said, I don't know how my clinic does this. So just be as specific as possible. Like, you don't want to restrict yourself too much in those qualitative questions. Anything that can be a quantitative question, just from an analytical standpoint, any way that you can break down what you're asking into a quantitative question, I'd say try to have that quantitative question, and then be really, really specific if and when you use qualitative assessment, because we did learn a lot. Sometimes stuff that we didn't mean to be asking for in that particular question, but it was really there were things that we wouldn't have thought to ask about. And so they can be really informative, but you just have to either be extremely specific or be very willing to kind of roll the dice and get a wide variety of information that will be very difficult to compile into one report on that question. If that makes any sense at all.
No, absolutely. And anybody who's done quantitative or qualitative data analysis, no, it's tricky. So free text is a blessing and a curse at the same time.
Absolutely.
Just thinking about all of that, you said how the breadth of information and the different groups that provided feedback. I'm wondering why you decided to go big. You reached out to a lot of folks, and I know Maryland has a lot of providers, and so I'm wondering what went into thinking about reaching out to everyone versus focusing on five groups to do outreach on.
I think that we were a bit ambitious in our survey launch, and we knew that there are a really wide variety of clinical settings that are addressing HCV. And so we really wanted to ideally, we would have loved to get even more variety, but to see from like an infectious disease specialist perspective, as well as someone who might be in infectious disease and STI, as well as someone who might be in family practice, somebody who might be in an emergency room setting. We didn't necessarily achieve all of the avenues that we wanted to address, but we did have, like you could see in that graph of how people identified, we did get a lot of different specialties. And so that was kind of the goal with that, because there's just, it looks different for everybody. And we wanted to capture that, especially people who are working in infectious disease and primary care settings.
Thanks for sharing that. Zakia, I'm assuming we can pivot into the wider discussion. There was a couple questions so far in the chat, and everyone, please feel free to put any questions or comments there, or raise your hand. We would love to hear from you. But Caitlin shared, do you have any issues getting fact sheets and documents approved at your state health department? And that includes the results sheet. For us, yes. I think we really tried to frame this not as at least so far, as something that we're disseminating widely. We're not posting. It was like sharing the notes after a meeting. It just looked nicer and had all the resources in one place. And so the framing of it like that helped us bypass some of those challenges. But I know that that's certainly a limitation for folks. Another way of disseminating would be to put this on a dashboard or things like that, and that would certainly have to go through our approval process, which is onerous. So I definitely hear you, Catherine. I don't know what your dissemination has looked like so far, and if you can share some of the challenges internally and solutions there.
Yeah, I would say very similar answer to what Danica gave. We also have a pretty rigorous process for anything that is going to go on the website, and especially anything that we're disseminating widely. So we haven't actually gone through that process for all of our findings yet, but we work with a graphic designer, which helps make sure things are clean and polished. And then we just have to go through the hoops of getting things approved at the state level.
Caroline asked if we completed these health system assessments before working on our elimination plans or after, and wondering how they can work off of each other. So Catherine, I don't know if you have any insights there.
So we completed the Hep B plan assessment before the elimination plan was completed. We treat our elimination plan as a living document. So we had a rollout of kind of the first round with it at about the same time as we were getting our provider survey results for the Hep C survey. And we do intend to update the elimination action plan with our findings.
Yeah, and for us, it's the same. We actually haven't publicly posted our plan yet, but the feedback from this has enforced and reinvigorated us that some of our approaches were the appropriate way to go, and then added some things. Certainly, I think this is where, and I know it requires more resources that can be challenging, but this is where also the key informant interviews were really beneficial to us, because we were able to ask those follow-up questions. We were able to get at some of the meat behind why things might not be happening or are happening, what resources places have. And so really being able to get that more granular information was really helpful. And we were able to incorporate some things in our plans according to that. And also to build those relationships a little more strongly than we have been able to in the past with surveys, and allow for an in to provide some of those resources that we're developing as a part of our elimination work. So some of the broader elimination planning, some connections with champions, building out a provider network for folks to refer to if they don't have on-site treatment or vaccination. And so this has definitely facilitated some of our elimination work through that lens as well. So it sounds like for Jen in Allegheny County, this is similar for her. So yeah, I think that's the point here. I think CDC would say this is the point, is we're really trying to be informed in our decision making for our elimination work, and this can go a long way to do that. But we can't make assumptions, you know, Catherine, like you said, folks assumed fibrosis score was still a player in terms of treatment, and that identified a gap that you didn't even know was there. So I think there's a lot for us to learn, and when we can listen. Does anybody else have any questions that they want to ask, or experiences they want to share? There are other folks who have done these assessments, as stressful as it has been for folks. I know it's almost 4 o'clock for us East Coasters, so you might be tired. So I guess one additional thought I had, Catherine, was just thinking, what do you wish you knew going into this before? What would you have wanted to know before starting this process again, to have maybe a more impactful, or what you feel as a more successful health system assessment?
I think having one thing that I've taken away from this, and it's actually informed how we are conducting our CLIA lab survey, is if we don't have the relationship with the people that we're trying to access, in this case, providers, in the lab survey case, lab directors, to reach out to people who might have those relationships. So trying to ask people at the local level who actually, you know, are in closer contact with our population of interest to help us disseminate, so that it's coming from someone that they might know better. That would be one way that I'm trying to incorporate our experience here into a better better response rate for a future survey. As we've discussed, I think there are some questions that I would have formatted differently or tried to disseminate. It's kind of a mixed bag because you don't want to make it so specific that you have a million questions. But getting more detailed information on our on some questions that we asked in a qualitative way that I think we could have done more in a quantitative way.
Thanks, Catherine. Sierra in the chat was asking some information or experience on how to integrate and assess key informant interviews into overall analyses and finding dissemination. Sierra, I am not a qualitative analysis person either, so but it certainly helped that we were doing this at only with a few sites. That definitely played into us being able to focus. And while we looked at some of these metrics across the board, we really were trying to focus within each health system. Our findings and our feedback document was specific to each organization, so it allowed for that qualitative side of things to be a little less complicated. One approach to doing this is our SWOT analyses, strengths, weaknesses, opportunities, and threats, and really trying to potentially categorize things into the testing and linkage and treatment barriers. Some of this is done really nicely in the questions appendix of the toolkit, but putting things into buckets that way and really thinking about what are strengths and what are opportunities for growth, and you know, hitting the SWOT of it. But happy to share more about that as well. But I think that those are, again, when thinking about a productive conversation for with the sites, really not necessarily a compliment sandwich, but really trying to accentuate what is good and highlight what needs improvement, but how that can be done, and not put the onus all on the group. And then in terms of findings dissemination more broadly, we will de-identify with all of these sites most likely. I think it would be a real uphill battle to try to put names of organizations with direct findings. So we'll certainly be doing aggregate work there, which will require us to boil down some of the findings a little more instead of keeping it at that or moving it up to that higher level versus being able to show that more granular information. I hope that's helpful. I'm not sure we were the most scientific about it. Anybody else have any thoughts, feedback? Just want to say you're terrified and don't want to do it or don't have capacity to do it. Hopefully this toolkit is helpful. Hopefully you don't have to reinvent the wheel. If you have any questions or fears, please don't hesitate to reach out to NASCED, and I'm sure they'll through some peer-to-peer work hopefully can support you doing that. Oh, somebody's excited. Yay, Wisconsin. I will say we found it really empowering. We met some really great folks. People another piece of something that was exciting by doing the key informant interviews and reaching out to different groups. We brought infectious disease and primary care and family medicine and OBGYN and the CMO together into the same room to have a virtual room to have the conversation. And I think hopefully that made some headway. We showed the health department was invested. We talked about national guidelines and expectations and priorities. And then we had the experts in the room from infectious disease working with these other groups to troubleshoot in the same room. So if you can bring some of that together, it was organic problem solving that was really, really exciting to see, and got us on the radar of some really important people to make this work happen. So through the surveys and providing that feedback through feedback reports, maybe sharing it with multiple folks in an organization could help to elevate some of these more productive conversations for troubleshooting. I'm glad this is hopefully positive for at least a few. Yeah, and Rachel, I hear you on capacity. It's definitely a challenge, I know, for every single one of us. So, but if you can start small or target where you can, hopefully, piecemeal and step by step is often the way we have to go in hepatitis. So do what you can with what you got, and you'll move things forward. Zakia popped on. I don't know if she's gonna cut us off.
Oh,
Close
no,
it
not at
out.
all. I just had a thought. So this past weekend, I was at the liver meeting surrounded by a bunch of hepatologists. And I don't know, I guess because maybe they just aren't really familiar of some of the work that you all are doing at health departments. So I think this is a great opportunity also for you all to educate them about the work that you're doing, and your elimination plans and your prevention work and your surveillance work, because they really don't know. So I think that's another great thing about this process as well.
Yeah, definitely. And I will say that was a weakness of ours. We actually avoided the hepatology departments. We didn't want them to dominate the conversation or have anybody feel sheepish about what they're doing. And but I think that providing the feedback to them would be really helpful. And I think figuring out another way to engage them with, all of our resources. But yes, agreed. Rachel with the
I'll just echo Rachel's point. Great work, Philly.
Oh, thanks, guys. Appreciate it. I'm inspired by you guys. That's why we are where we are. Yes, and just to highlight Zakia's point, if you have any questions moving forward, excitement, trepidation, want more resources, our feedback report is on the NPIN, which is really challenging to navigate. So if you want me to directly share it with you, I'm happy to as well.